Hi, my name is Allison Dart. I'm a pediatric nephrologist. I've been working with the Finnish screening project to help develop pediatric screening algorithm and treatment recommendations to help guide primary care practitioners in the treatment specifically of children identified as being low risk after screening.
So the purposes of this presentation are to take you through the pediatric screening algorithm and then to specifically go through the treatment recommendations to help guide the primary care practitioner who may be less comfortable with managing children with chronic disease.
Right, so I'll start by taking you through the pediatric screening algorithm. As the risk equation has not been validated in children, we can't apply it to kids at this point. Therefore, all children between 10 and 18 years of age will be triaged according to more traditional parameters. The first one is their hemoglobin A1C. So if it is above or equal to 6.5%, then the recommendation is an urgent referral to the Diabetes Education Resource for Children and Adolescents here in Winnipeg. If their A1C is under that threshold, then they are stratified according to their blood pressure, their estimated GFR, and their degree of albuminuria. Also, if the hemoglobin A1C is between 6.1 and 6.4%, we recommend screening with either an oral glucose tolerance test or a fasting blood glucose to either make the diagnosis of diabetes or to rule it out because the A1C is not actually validated as a screening test in children. So those patients that will be triaged to primary care are those in the low risk category. And you can see here in yellow, the children risk category will be those with stage 1 hypertension, which is a blood pressure greater than the 95th percentile to the 99th percentile plus 5 millimeters of mercury. And I'll explain that a little bit more as we move forward here. If they have an eGFR between 75 and 90, or if their albumin-creatinine ratio is between 30 and 30, then those children will be triaged to the low-risk category. And we've developed some pediatric-specific treatment guidelines to guide the primary care practitioner in further working up these patients and management for them. Those that are stratified in the intermediate and high-risk categories, as shown on this algorithm, will be referred to pediatric nephrology in Winnipeg, either as an elective referral if they are an intermediate risk, or an urgent referral if they are high risk. And the high-risk patients include those with an estimated GFR less than 60 or an albumin-creatinine ratio greater than or equal to 100. Those with no current risk are those shown here in green, and those patients will not have any particular intervention other than lifestyle counseling, including diet and exercise recommendations. This slide shows the treatment recommendations that we've developed to help guide treatment for hypertension, low eGFR between 75 and 90, as well as an microalbuminuria, so an ACR between 3 and 30. And I'll take you through each of these algorithms separately. I just wanted to first touch on two issues that are specific to pediatrics that many healthcare providers may or may not be comfortable with. The first is the interpretation of a blood pressure in children, and the normal values are very different than what you would see in an adult population. The normal blood pressures for children come from this resource called the 4th Report on the Diagnosis, Evaluation, and Treatment of High Blood Pressure in Children and Adolescents. This document was published in 2004, but the targets are still the same. So blood pressure in children is dependent on their sex, their age, and their height percentile. So when you're evaluating a child, it's important to measure their height before looking at their blood pressure and to plot on one blood pressure tables. These are available online and are attached to a PDF on this website for your evaluation. Also, there are many apps that you can download in which you just input the pertinent numbers and the percentile is generated for you. So there are a lot of electronic resources that can help, and some references to these will also be included on the website. A pocket guide to blood pressure measurement in children is also available on the website, which includes these blood pressure values, and is a very valuable resource and a quick read to get you up to speed on interpretation of blood pressure in children. This is one of the tables from that handbook, and it separates blood pressure values for you as far as whether a child is pre-hypertensive or meets criteria for stage 1 or stage 2 hypertension, again based on their age and their height. So the definitions of hypertension in children are listed here. Normal blood pressure is less than the 90th percentile. Pre-hypertension would be greater than or equal to the 90th percentile, or 120 on 80. And a definition of hypertension is once the blood pressure is greater than the 95th percentile. And this is further staged as listed here. So stage 2 would be greater than the 99th percentile plus 5 millimeters of mercury. These patients would be triaged to see nephrology, whereas those with stage 1 would be managed by primary care. And those ones that I want to focus on. One other thing to remember for children is that it's very important to look for secondary causes of hypertension, which may not be the case in many adults. And I've listed here a long list of things that can cause hypertension in children, and this is for your reference and will be alluded to in the treatment guidelines as well. The other thing to note is that an estimated GFR in children is calculated with a different formula than what is used in adults. This formula is a constant 36.5 times their height in centimeters divided by their serum creatinine. So you can't rely on the estimated GFR that's reported by the lab, and you must do this calculation on your own. Again, there are apps that you can download that will calculate it for you if you input their height and the serum creatinine. This is important when you're evaluating patients that have been screened in this initiative. So now I'll take you through the treatment recommendations. I'll first start with the blood pressure. So all patients with stage 1 hypertension will be triaged as low risk, as I mentioned. The most important thing is to evaluate for symptoms and for signs of a secondary cause of hypertension that can be treated. And that's where these recommendations in 1.2 come from. So specifically to do a physical exam, looking for signs of coarctation of aorta, and then to do some screening blood work as listed here to look for secondary causes. If there's an abnormality in their eGFR or albumin-creatinine ratio, or if there's a suspicion for a secondary cause, we do recommend a referral to nephrology. We also recommend assessing for comorbidities, specifically diabetes with an hemoglobin A1C, as well as a fasting cholesterol panel, and to assess for smoking status. If there is no obvious cause elucidated from the initial workup and they are lean with a BMI less than the 85th percentile, further workup may be required, and we do recommend a referral to nephrology in this case. If we are happy there isn't an obvious secondary cause and the child is overweight or obese, then a diagnosis of obesity-related hypertension is made, and the recommendation is to initiate dietary counseling, 2 to 3 grams sodium restriction, DASH diet, exercise 60 minutes per day, as well as specifically calorie reduction and avoidance of sugar-sweetened beverages. We recommend follow-up monthly to assess progress, and then at the 6-month mark to assess their blood pressure to see if it is now below target. If not, then we recommend pharmacologic intervention at that time. The first-line therapy for children with either chronic kidney disease or obesity-associated hypertension is an ACE inhibitor. or an angiotensin receptor blocker. I've listed the starting doses here in 1.7. If there's a contraindication to these medications, then second-line therapy would be amlodipine or another calcium channel blocker. And again, the starting doses are listed here in 1.8. We recommend targeting a blood pressure less than the 90th percentile unless the child has chronic kidney disease, in which case we recommend a more aggressive target of less than the 50th percentile. If the blood pressure is not responsive to a maximum dose of one medication, or if the blood pressure worsens and progresses to stage 2, then we recommend referral to nephrology at that time. Finally, if the eGFR is also low, less than 90 mLs per minute per 1.73 meters squared, or if the child has albuminuria or diabetes that developed during the course of follow-up, then we also recommend referral to nephrology. Okay, so we'll now move on to the eGFR category. So again, those patients with an eGFR between 75 and 90 will be considered low risk. The first recommendation is to repeat the serum creatinine after a period of hydration to ensure that it wasn't a transient finding. And again, to remember to input the creatinine into the Schwartz formula to determine the eGFR. We also recommend assessing for hypertension and albuminuria. If they are also present, then we would recommend referral to nephrology. If the creatinine is confirmed in the same range, then we do recommend screening electrolytes, albumin, calcium phosphate, PTH, and a urinalysis, specifically to look for concomitant hematuria as well as a renal ultrasound. If the PTH is increased, we recommend a trial of vitamin D. If the hemoglobin is low, with a low MCV, we recommend a trial of iron. And if all above are normal, then we recommend repeat labs every 6 months to monitor for signs of progression. If the eGFR falls below 75 mLs per minute per 1.73 meters squared, or if the eGFR is declining greater than 5 mLs per minute per 1.73 meters squared per year, or there is evidence of structural renal disease on ultrasound, then we would recommend referral to nephrology. Finally, if microalbuminuria is noted and the patient is triaged as low risk with the ACR of 3 to less than 30, then we again recommend confirming the presence of albuminuria. In children, there is a high prevalence of orthostatic albuminuria. Therefore, a first morning urine or an overnight urine collection is required to confirm that the albuminuria is pathologic. So that is the first recommendation. We also recommend assessing for concomitant hypertension and eGFR. If it's below 90, then we recommend referral to nephrology. If the albuminuria is confirmed and the child does not meet criteria for referral, then we recommend, again, screening electrolytes, including albumin, calcium, phosphorus, PTH, and a urinalysis, as well as a renal ultrasound. If all labs and the ultrasound are normal, then we recommend repeat screening with, again, a first AM sample in 6 months. And only if the albuminuria progresses to the macroalbuminuria range or is associated with hematuria with greater than 20 RBCs per high-powered field on microscopy or red blood cell casts, or if hypertension develops or the eGFR is less than 90, then we recommend referral to nephrology. So that completes the review of the low-risk treatment recommendations. If you have any questions, I'd be happy to address them at any time, and my contact information is also available on the website.